So good afternoon and welcome to the session. I want to first thank Wounds Canada for the opportunity to offer you this session entitled The Pro Advantage, Scientific and Clinical Evidence for Delivering Cost-Effective Negative Pressure Wound Therapy Without Sacrificing Quality. My name is Deanna Andel and I'll be moderating this session for you today. A little background on myself: I'm a clinical nurse specialist certified in wound care by the WOCC, presently working as a senior clinical consultant for Cardinal Health. There will be 3 guest speakers following me today. I'll introduce you to each of them just prior to their presentations, but please feel free to access their full bios on the Wounds Canada conference app. Throughout the session, please remember to input any questions you have for the speakers into the Zoom Q&A. We'll collate the questions and pose as many of them to the speakers as possible at the end of the session. So let me take a few minutes to give you an overview of the Cardinal Health Negative Pressure Wound Therapy portfolio of devices and products. Cardinal Health's Canadian offerings include the SPED and Pro family of devices that can be utilized across the continuum of care. And with well over 1.6 million days of therapy supporting clinical outcomes, it's easy to see why Cardinal Health is a trusted source for negative pressure wound therapy. The Cardinal Health Pro NPWT device is simple, reliable, and effective. Its intuitive design and compact size make it an easy choice for clinicians. And weighing in at less than a pound with a quiet, high-powered motor makes it a popular choice among patients as well. Other features of the Pro device include 1,000 days of therapy and up to 18 hours of battery life. The Proto-Go Kit is a convenient way to ensure patients have no interruption in therapy when transferring from one care setting to another. The convenient kit provides you everything you need for 10 days of negative pressure wound therapy. Each kit includes a device with 10 days of therapy, 3 large dressing kits, 2 300cc canisters, 1 carrying case, and 1 AC power adapter. And from multiple dressing sizes to carrying cases and Y connectors, Cardinal Health offers a full suite of dressings and accessories designed to meet your negative pressure wound therapy needs. Cardinal's uniquely patented simultaneous irrigation technology is the only NPWT system that gives you the option of delivering a topical solution into the wound bed at the same time NPWT is applied. This therapy helps to reduce bioburden, remove debris, and add moisture to the wound bed. We all understand that a moist wound environment is optimal for generation of granulation tissue and healing. For more information on Cardinal Health's NPWT portfolio, remember to stop by the Cardinal Health booth. Following today's session, we have a multitude of literature pieces as well as product videos for your viewing. Now, I'm honored to introduce you to our first guest speaker, Dr. Lawrence Lavery. Dr. Lavery is the director of the Diabetic Limb Salvage Program at Parkland Hospital and the director of the Diabetic Foot Research Group in the Department of Plastic Surgery at the University of Texas Southwestern Medical Center in Dallas, Texas. This research group has focused on the epidemiology, classification, diagnosis, prevention, and treatment of diabetic foot ulcers and infections. His team has participated in 18 randomized clinical trials to evaluate novel prevention and treatment strategies. Dr. Lavery is a recipient of the Carol Baker Diabetic Foot Award, given to honor scientists and clinicians who gave major contributions to our understanding, prevention, and treatment of diabetic foot disease. Negative pressure wound therapy has changed the management of complex diabetic foot wounds. Dr. Lavery is a co-author of the Randomized Clinical Study to compare negative pressure wound therapy with simultaneous saline irrigation and traditional negative pressure wound therapy for complex foot infections. Dr. Lavery, thank you for joining us today.
Thank you for that introduction. It's a pleasure to join you today. My topic is randomized clinical studies to compare negative pressure wound therapy with irrigation and traditional negative pressure wound therapy for complex foot infections. The learning objectives today are really centered around some new evidence from 4 randomized clinical trials that use negative pressure wound therapy with different approaches for irrigation or installation. So I want to discuss the recent publications, some of which have just come out in the last few months. I want to then explore the implications for these applications in your daily practice and how they may impact your care and clinical outcomes. So this is one of the first papers from our group, that was just published this year. My colleague, Katie Davis, was the first author on this. This was a single site prospective randomized clinical study. It was a 16-week evaluation period. We evaluated 3 treatment groups in this study: traditional negative pressure wound therapy with kind of the market leader, the Saline product, traditional negative pressure wound therapy with the Pro product, and then negative pressure wound therapy with simultaneous saline irrigation. And for this study, we used a flow rate of 15 cc's per hour. So this was a study where there were 90 subjects, 30 people in each treatment arm. All of the groups were treated with 125 millimeters of mercury pressure throughout the study. They were randomized in a 1-to-1-to-1 ratio, so 30 people in each treatment arm. And in the irrigation group, it got simultaneous irrigation with 15 cc's of normal saline. People were followed in the outpatient clinic pretty much according to our standard of care. They were seen every 7 to 10 days for a 12-week study period. So if you look at the clinical outcomes during the index hospitalization, there was no difference in the 3 treatment groups. The people that had an incision and drainage for their infection, an amputation, or that lost their leg are very similar across treatment groups. The number of surgeries was about 2 per group. The hours of negative pressure wound therapy were very similar. The length of hospital stay and the time to final surgical closure were not significantly different in any of the 3 treatment arms. The primary outcome from the study was the proportion of wounds that healed during the 12-week evaluation period, and there was no difference in this outcome. 63% of people healed in the group that got simultaneous irrigation. 50% of people healed in the negative pressure wound therapy device without simultaneous irrigation, and 47% healed in the Saline product. There was also no difference in the outcomes after hospital discharge. So if you look at the p-values, there's nothing that even approaches significance for the duration of antibiotic exposure or treatment, the people that were healed at the end of the study, the time to healing, or the rate of wound failure or wound dehiscence during the follow-up evaluation period. The next slide is a survival analysis, basically showing the median time to healing over the course of the study. And these are essentially overlap each other, and there's no difference in the survival analysis. The next study is a study that was funded by the American Diabetes Association, and it used a similar approach. It was a single site randomized clinical trial. It was 16 weeks in duration. We evaluated 2 treatment groups, traditional negative pressure wound therapy and negative pressure wound therapy with simultaneous irrigation. And in this study, we used Pronto-San at a rate of 30 cc's per hour for the simultaneous irrigation group. Yeah, this is similar. So people were randomized in a 1-to-1 ratio. Similar to the first study, the standard pressure was 125 millimeters of mercury. And again, people were followed up every 7 to 10 days over the 16-week study duration. The primary outcome, just like the first study, was the proportion of people that healed during the 16-week evaluation period. There was no difference in these two groups. 60% of people healed in the group that got simultaneous irrigation. 59% of people healed in the group that got standard negative pressure wound therapy. And again, this is the survival analysis, which basically shows that these curves are essentially overlapping, so there was no difference in the time to healing during the follow-up period. So again, like the previous study, if you look at the rate of people having incision and drainages, partial amputation of their foot, amputation of their leg, the number of surgeries, hours of therapy, there's no difference in these treatment groups. And the same if you look at people during their follow-up closure time. The next study is a study that was done that was led by Paul Kim, who at the time was at Georgetown University. He has subsequently joined our group at the University of Texas Southwestern Medical Center in Dallas. And this was also a randomized clinical study that kind of highlighted the two treatment groups with red squares. So one of the groups was treated with negative pressure wound therapy with installation with Pronto-San, again, an antiseptic solution. And the other group was treated with traditional negative pressure wound therapy without installation. Again, there were 93 people in the installation group, 90 people in the group that didn't receive installation. So the main significant outcome in this study was that there was a difference in quantitative bacterial cultures in people that were treated with saline between the first surgery and the first dressing change. All the other clinical outcomes, there were no differences in wound healing, in the time to heal, or in the rate of infection in the two treatment groups. So kind of a surrogate marker for infection or getting rid of infection was positive, but none of the important clinical outcomes were different. And then the final clinical study, again, was a study that was led by Paul Kim. And, you know, I was able to also participate in this study with Paul. And this was a single center randomized clinical study. And they compared normal saline with Pronto-San and evaluated 49 people in the normal saline group, 51 people in the Pronto-San group. So one of the measures that was included in the study was the time to the final surgical procedure, kind of as a surrogate measure for success. So the idea was, we're going to use negative pressure wound therapy to prepare the wound bed to either be surgically closed or covered, and that could include a split thickness skin graft, coverage with other products like Integra, which I think was one of the favorite products used at Georgetown. And so there's a time that the wound was deemed ready, and then the time for them to actually go back to the operating room and be closed or covered. And then the third outcome was the proportion of wounds that were healed after 30 days. So there was faster time where the wound was prepared, where they had their final surgical procedure, and that favored people that received normal saline. It was about a 2-day difference. There was no difference in wounds that were closed or covered or wounds that were closed in 30 days, either in the intent to treat group, which is the data in the in the top half of this table, or the per protocol group, which is the bottom part of this protocol. And in fact, none of those variables mattered in either intent to treat or per protocol. It was the same results. So in conclusion, currently there's no evidence that any negative pressure wound therapy system is superior. There are a number of studies that have compared systems, and actually several of the studies, the comparative group no longer is in the marketplace. But small studies show that traditional negative pressure wound therapy, no matter what the product or design or company, perform essentially the same way. So essentially, the kind of the motto, a pump is a pump is a pump, holds true. So the technology is similar, its application is similar, and the results are very similar. We really had high expectations, especially in the diabetic foot arena, I would say, that adding a source of irrigation or installation would allow us an opportunity to use antiseptics at the very least, and maybe other products in the future, to change the wound bed so it healed faster, it was less susceptible to infection, and we would make the next big jump in treating complex wounds. But the outcomes look like they're very, very similar, whether you use installation or irrigation, whether it's normal saline. And right now, the only two things that have been evaluated are normal saline and the Pronosan antiseptic. And in these studies, there's not a significant difference in the healing outcomes or in postoperative complications based on the product, the flow rate, or if you use negative pressure wound therapy with irrigation or not. There's no increased risk of adverse events. There's no significant difference across integrated irrigation delivery methods. So with that, I will stop, and thank you very much for your time and attention.
Thank you for that presentation, Dr. Lavery. The translation of clinical research to clinical practice brings great opportunities to improve patient care. Now you'll hear from two Canadian wound care experts that have been able to put research into practice and deliver reliable outcomes in a complex healthcare environment. Susan Chandler currently works in the rehabilitation sector of Toronto, Canada as a clinical nurse specialist in wound prevention and care at Providence Healthcare, part of the Unity Health Network. Susan holds a master's degree in clinical science, wound healing from the University of Western Ontario, and is a nurse specialized in wound ostomy and continence with wound ostomy continence certification from the Canadian Nursing Association. By the way, Susan also has a poster in the Wounds Canada Poster Hall, number 0016, titled Patient Transition from Hospital to Home with High Exudating Wounds, Bridging the Gap in Negative Pressure Wound Therapy. So please stop by and take a look at Susan's work with the Cardinal Health Proto-Go system. Rose Raizman is passionate about helping people maintain optimal health. She is presently working as a wound care nurse practitioner at Scarborough Health Network, a community hospital in Ontario, Canada. Rose is a registered nurse extended class, primary health care nurse practitioner, nurse specialized in wound ostomy and continence care, Wound Ostomy and Continence Canada certified, and holds a Master's of Science in Nursing. Susan, Rose, thank you both for joining us today.
Hello, Rose and I will be discussing our experiences with the Cardinal Pro and the Proto-Go canister negative pressure wound therapy system. For the site which I'm based at, we had many challenges for patients transitioning or leaving the hospital who required negative pressure wound therapy canister therapy. Local health integration networks, the LINs in Ontario, have greatly differing criteria. And for hospitals referring to different LINs, this often causes complex situations. There is problems with availability of negative pressure, waitlisting for patients due to the high numbers of the negative pressure referrals, and also dearth of machines available. When leaving hospital sites for our patients, even if they're just going out for a short time or to a regular hemodialysis appointment, for instance, the negative pressure canister vacuum must be discontinued, and a standard wound dressing is applied until the patient returns. This results in a loss of the advantage negative pressure wound therapy brings to advanced wound care. We were all very much aware of negative pressure's advantages for a patient's wound: the maintenance and continuity of the wound healing trajectory, a closed system that provides a barrier to external contamination, continued reduction of localized tissue edema, and the maintenance of division of cells and the formulation of granulation tissue. In addition, we have ongoing improvements to the perfusion of the wound vent, known as angiogenesis, and the removal of excess exudate that slows the cell growth and proliferation. And this is particularly applies to the high exudating wounds that the Proto-Go was onboarded for at my site. The protection of peri-wound from moisture-associated skin damage is obviously a feature that negative pressure also helps, keeping the wound bed moist and warm and giving physical support for the wound. This is why that when we advocate for a canister vacuum system, we usually look at many of the criteria listed above. Having onboarded the Proto-Go for a 10-day system, primarily for patient discharge, we've also thought how we might also use it for a wider patient population. So considering that we use the negative pressure with a canister for high exudating wounds, we're considering patients for not just discharge, but for home visit, for patients in isolation or on contact precautions, for rehab and community transitions to the emergency department, and to outpatient appointments where normally standard dressings would have to be applied instead of the negative pressure. Consider it also for hemodialysis and for patients that we would not necessarily consider for canister vacs because they have a high risk of leaving against medical advice at any stage. And with an expensive standard hospitalized system, this isn't a practicality. And unfortunately, this often means that these patients don't get the canister vac that they so often need. I'll pass it over to Rose now.
I'm working in acute care hospital, and to have a smaller negative pressure device give additional benefits to Susan had indicated. In addition, some patients would benefit if the system is easy to transfer from the wall suction to the mobile negative pressure. And I will share with you a case study when we're talking about this advantage. This particular case study is a 77-year-old male who have past medical history of non-insulin dependent diabetes mellitus, which is currently treated by Humalog and metformin. He has hypothyroidism. He has extensive cardiac history and had 5 times CABG in 1991. He had hypertension, CHF, and peripheral vascular disease with right below knee amputation. Currently, he was presented for the ICD insertion on June. However, pacemaker site get infected and it needed to be removed on July 14. Following the removal, patient was put on the hospital negative pressure with installation of the liquid, and needed to transfer home without interruption to the negative pressure. For this reason, we chose to try a Cardinal system, which is very portable, easy to apply, easy to teach, and patient and both staff were very happy because the system was very easy and light to carry. And you can see that even though this patient who was on 3 negative wound therapy devices, standard hospital, then Cardinal, then standard community, patient healing was not affected, and you can see a timely wound trajectory and healing. Next slide, please. So the feedback from both family and staff was very good. Patient perspective, he stated that Cardinal system was the easiest and lightest to carry around and easiest to understand. Staff perspective, including myself, I really liked that there was ability to switch interfaces without switching device. And it was very easy to operate and very easy to teach staff. It took me exactly 5 minutes to teach the staff because we switched him from standard negative pressure with installation to portable device day prior to his discharge. And I needed to educate day and night staff about the device, and it was very easy, 5 minutes. And then on the transfer of accountability, they were able to train the trainer. And there were very easy transaction to the home as well. So the next case study is actually a patient who was not transferred home, but stayed in the hospital for duration of almost 6 months, and now is actually transferred to Susan's care at Providence, but completely epithelialized and healed. His past medical history is compound fracture, diabetes, which was insulin dependent, and a cerebral palsy. He was admitted to our hospital with infected wound from the fracture. There was a bone involvement, and was consulted for salvage of the foot. They wanted a negative pressure, standard hospital negative pressure device, but it was very heavy to carry around and also very costly to have it for long duration. We knew that patient is going to stay in the hospital for at least 3 and maybe even longer months. So he was connected to the wall suction, but patient was mobile and he wanted to move around. And this light and easy to care Cardinal system was very good to use. So patient perspective was that it's light and easy to take around. His mood have improved. And he was very happy. And when I received the patient, he was very combative and was stated as non-cooperative and non-compliant. So after we moved him to the different therapy system and explained that he will not have a limit and he can move around, he was become easier to communicate with and was way more pleasant in communication and also happier, according to him. Next one. And the third case I would like to present is a patient who had past medical history of dementia, hypertension, insulin, dependent diabetes mellitus, and she was admitted due to the breast cancer. Lumpectomy was performed, she was discharged, and I've seen her in the clinic because there was a seroma in the wound, but patient needed a fast closure because chemotherapy was very important to start as early as possible. And she was a resident of long-term care, and they didn't have an access to negative pressure device. So Cardinal mobile, portable, and easy to operate device was very timely, very easy to teach. The long-term care staff had no problem to change it. During the length of healing, we needed to change different interfaces, antimicrobial and foam interface, gas interface, and it was very easy. The only thing which was needed to be changed is an interface. It was the same system. feedback from the long-term care staff, from the patient was very, very positive.
So we know there are lots of advantages for the patient, especially with a 10-day canister negative pressure system. As a result, we get continuity of care. Patients sent home for discharge are not waitlisted for the provision of negative pressure. We continue with the quality wound care and seamless transition to the next care provider. We have confidence in the treatment, not just for us, but for the patients as well. There are no grey areas as to what happens next to these patients going home. Will they have a VAC when they get home? We reduce the number of dressing changes from a standard dressing on a high exudating wound, because we know that negative pressure only needs to be changed 3 or 2 twice a week. There is an ease of dressing and dressing maintenance for the challenging wounds. For the care providers, there are lots of advantages. Continuity of care. Again, the patient's not waitlisted for provision of negative pressure. It takes the pressure off community partners for the full assessment immediately on discharge, giving a seamless discharge and ongoing wound care. It's cost effective. We're not having to provide higher costs for machinery that we had to in the past, and also delaying discharge, where we were keeping patients up to a week, sometimes for 10 days, until a VAC machine, a negative pressure machine, was available. The compatibility of reusable products with the negative pressure device is no longer an issue because of the grab-and-go package. We send home a complete 10-day system. The critical education, though, required for the patient and family is very straightforward. How to charge the device, how to turn the device on and off, how to change a canister should they need to if the exudate is excessive, understanding for them of what is a normal exudate, the amount and consistency, and that really talks to when frank bleeding occurs. How to problem solve and reinforce if the negative pressure is lost. This is something that we teach our staff, and as a result, we also need to teach our patients going home so that they don't lose the negative pressure, and how to remove the dressing if a negative pressure is lost so that we avoid maceration of a wound bed. We found this with the case studies that we presented and other examples of patients, and found it a very successful system. So we hope that that concludes our talk, and if there are any questions, we'd be happy to take them. Thank you.